Welcome, everyone. Good afternoon. My name is Nadia Islam, and I am one of the principal investigators for the National Center for Engagement in Diabetes Research, or National CEDER. And I'm really pleased to welcome you to our Learning Exchange series. We have a real treat in store for us today. We'll be hearing from partners who will be discussing from clinic to community, partnering with Cooperative Extension to improve diabetes health outcomes. Next slide. So this is our session today. We'll be guided through the session by Dr. Vanessa Da Silva, who I'll introduce in a moment, and she will be introducing the remainder of our speakers who will be sharing their experiences about partnering and delivering services through cooperative extension, which is a hugely valuable community academic resource that I think in some settings is, if not untapped, undertapped. And so we really hope to raise awareness of the amazing work that's going on through extensions and hopefully facilitate future collaborations as well. Next slide, please. So as I mentioned, this Learning Exchange series is brought to you by CEDER. CEDER is a national center that was funded by the National Institutes of Health in 2023 with a goal of providing resources and technical assistance to promote partnership engagement in diabetes-related research and programs. Our larger vision is really to foster both community-led as well as community-informed diabetes research by integrating multi-sector engagement across the research spectrum. And I think the real jewel of CEDER is our partnership hub. We bring together over 18 different academic schools of medicine and schools of public health, and more than 10 regional and national community-based organizations that are serving diverse populations all over the country. And each of our cores are co-led by an academic and community partner. So we really try to model what we are providing technical assistance and resources on, which is bidirectional, sustainable, effective community partnerships. If you scan the slide, if you could just go back one quick moment, there is a QR code here, and I believe we'll put CEDER's website in the chat. CEDER, although we are funded by the NIH, we are not a research study. We are a center that provides resources and services. And so we really encourage you to utilize us as a resource. We provide consultations and studios to community partners, to investigators, to health system partners, to more effectively integrate partnership into research that's designed to improve type 2 diabetes related outcomes. Next slide, please. So today's Learning Exchange series has the following goals. Our Learning Exchange series has the following goals: to share examples and best practices of positive research community partnerships that really highlight the value of community engagement in type 2 diabetes research and programs. And we hope with this learning exchange that participants come away with a greater understanding and expertise around a range of topics. This includes policy, best practices in communication, grant writing, community-based participatory research, as well as other topics. We've had a robust learning exchange series over the last year, and it has included a wide range of topics, some of which you see here: grant writing for partners, best practices in community-based participatory research, new advances in obesity-related research. And so we really try to tap into the breadth of expertise across our partnership hub to highlight the most cutting-edge topics in advancing type 2 diabetes-related research. So participants of our learning exchange include our partnership hub members, the clients that we serve, and the wide range of individuals interested in type 2 diabetes related research and partnership engagement. Next slide, please. So let's move on to today's webinar. Next slide, please. So as I mentioned, today's webinar is titled From Clinic to Community, Partnering with Cooperative Extension to Improve Diabetes Outcomes. I'm really thrilled to introduce our moderator for today's event, who is Dr. Vanessa Da Silva. Dr. De Silva was introduced to us through our partnership hub member, Spiro Manson, and we have just been so fortunate to be linked to her work and the partners across the country that are associated with Cooperative Extension. Dr. Silva is an extension specialist at the School of Nutritional Sciences and Wellness at the University of Arizona. She also serves as director of the CDC-recognized University of Arizona Diabetes Prevention Program, which is available throughout the state of Arizona. In Dr. De Silva's work, she effectively bridges the gap between research-based knowledge and the practical needs of communities, really focusing on chronic disease prevention and management through diet and lifestyle changes. She has over a decade of experience leading community nutrition and public health outreach programs through cooperative extensions. So without any further delay, I will turn it over to Dr. De Silva. Thank you for joining us today.
Thank you so much. Thank you, Nadia. So today's presentation, you'll hear from several of us representing several extension programs across the country. You will learn about extension and what our role is in providing evidence-based health outreach focused on diabetes in community settings, and hopefully identify some opportunities to work together, whether it be through referral to our programs or partnerships in research or other implementation. Again, opportunities to work together on research and evaluation. So as Nadia said, we have been around for a while. Extension has been a lot of times we are underutilized as a community resource or as a research resource. So let us know if you have any questions, and we can move forward with the next slide, please, Emma or Sarah. Next. Oh, the whiteboard. Sorry, let's go back to the whiteboard. First, we have a question to you, to all everybody who's attending today. We're going to put up a whiteboard, and we'd like you to type in where do people in your community get support for diabetes prevention or management? Just hover your mouse over the whiteboard and should be able to click and start typing. Community-based organizations. Are well, it looks like panelists on there.
I'm not sure if actually folks can edit.
Yeah. Are people able to edit? It can also put it in the chat.
Oh, okay. Please put it in the chat then. Sorry.
Thank you. Yeah, the chat works. This is something else Extension does. We're flexible. We go with the flow. We find solutions. So health departments, hospitals, FQHCs, nonprofits, health departments. So again, the question is, where are people in your community finding support for diabetes prevention and management from a diabetes educator, physicians, through a local extension office, family members, primary care, dietitian. So a lot of health provider answers, a few people mentioning extension offices. Not too many resources were San Luis Valley, hospital systems. So you get this breadth of places where people are getting support for their diabetes prevention and management. So can we go back to the slide, please? This is relevant to the whole conversation because to understanding what cooperative extension is. So in the answers we got from family member, so the person most close to you is your family, your friends, all the way to maybe a PCP, a nonprofit. In the middle, you might have a CHW, a dietitian. So there's a whole breadth of places, and some folks even mentioned access. So not that much opportunities for help here. So wanted to get an idea of who our audience are, who you guys are, and how familiar you are with cooperative extension, because that will help me and the rest of us guide us through this. So can you answer the poll? How familiar are you with cooperative extension? Never heard of it. I've heard of it, but I'm not familiar with what it does. Or C, I have participated in or interacted with extension programs or possibly work for extension yourself. Does everybody have a chance to make an option, make a selection? All right, we could probably close the poll and see. So a tenth of you more or less have never heard of extension. A third have heard but aren't exactly familiar with what it does. And about half have participated or interacted with extension programs. This is wonderful. Good to know. So next slide, please. To explain what extension is, it's helpful to understand why extension is. Why do we have extension? And the reason extension was created over 100 years ago by President Wilson in 2014 by signing the Smith-Lever Act, is because oftentimes evidence is created at the university, gets reported in a journal or in a report, and then sort of dies there. Nothing happens to it. You see this often probably in your own work. Sometimes, there'll be a grant, 5 years, this great project, a program gets created, great results, and then the funding period ends and that program is never seen again. This is not unheard of. And this has been the case for a while, or this was the case for a while. So they created this, this infrastructure of cooperative extension to help with that implementation gap that existed, where the solutions that research was finding to problems, so that evidence that was being built wasn't really reaching the people that needed it the most. Or the other thing that happens a lot is it takes a long time for that newfound evidence to actually be translated into practice. So that happens a lot. I'm sure you have all experienced that. Sometimes a program may exist and may have tried to be implemented, but it doesn't really fit that local context, that local community. And what ends up happening a lot of times is that issues remain unaddressed. The community remains suffering from the same issues. And therefore, extension was created, next slide, to address that implementation gap and close it, become this bridge. So the idea of extension is that it will both help generate research, but then make it accessible in the real world, in everyday settings. The idea is that evidence becomes translated, and extension is that path for this to happen. That's why extension exists. And that not only is it made available and translated, that it actually is having an impact, and that it is accessible and needed. Can you go to the next slide, please? So what was it, when they created extension, what they came up with was this large system that was embedded in every land-grant university in our country and in the territories. So that's what's listed here. All of those dots, stars, and green squares are, I believe, we're at 75 or so land-grant universities at the moment, give or take. So every state, wherever you are right now in the country, will have a cooperative extension service in your state. In Arizona, the University of Arizona is the land grant. So the idea is that extension professionals are part of the university system. But it goes beyond the university system. And when you think of the University of Arizona, you're thinking Tucson. When you're thinking University of Florida, where I went to, you're thinking Gainesville. Can we go to the next slide, please? But really, this is a better depiction of the coverage of extension. The reach that we have is in most counties and parishes of our country. I think we have 3,000 counties and parishes. We are in most of those counties physically with a brick and mortar extension office that you might or might not have seen, but your county most likely either has an extension office or is served by a neighboring extension office. So this infrastructure is really designed for scale, right? So it's not just the main campus of the land-grant university. It's not just Tucson or Athens or Gainesville. It is the whole state that is served by cooperative extension. It is unique in its reach. It is also unique in the fact that the extension professionals are in the counties as well as being on the main campus. I'll talk about that in a second. And that because we are part of we were funded initially by a federal bill, we are funded by taxpayer dollars at the county, state, and or federal level. This means that and a lot of funding by federal grants as well. This means that most of our programs can be offered for free or for very low cost. And any costs that a program has to have is just to recover the expenses of delivering that program. It is also designed for local needs when we're offering a program. We adapt locally, whether it be through recipes, language, or anything else, just the fact that we have people locally. Our workforce is also unique, and I'm talking about that in a second. And the most important thing that we have through extension, because of the way that it's structured, is the trust of the community. We are the face of the university in the community. The people trust the university, the fact that we are bound. Our mission is to deliver evidence-based education. And we have longstanding partnerships and relationships in the community, which brings that trust. Next slide, please. So it's not just that reach of being in most counties and parishes of the country. It is also the way that it was designed, the workforce. So what you have is a cohort of extension professionals that are on main campus or at research centers that the state might have. So those would be a PhD level, campus-based, they call them extension specialists. That is what I am and most of the other panelists are. So again, either on main campus, like at the University of Arizona, or at research centers, ag research centers that the university or the state might have. The role of the specialist as that PhD level, they often have a research appointment in addition to their outreach extension appointment. They are there to generate research themselves, interpret existing research, develop programs or adopt evidence-based programs, and collaborate. Collaborate across state lines and also across the counties. So then we have each county that, again, extension will look different in every state. Some will have more or less of each of these professionals, but the counties have county-based faculty, which we call extension agents. Some states might have different names for them. So again, bear with me, but this is broadly how I learned extension. Those are local experts. They are program leaders in their county. Sometimes they serve multiple counties, and they build local partnerships, and they are helping plan and deliver programs. They are supervising other staff who are community educators often. They may be CHWs, volunteers, peer educators, and who are delivering a lot of direct education and other kinds of programs, PSC, policy system and environment programs, and really providing culturally relevant education and support to community members. So it's this network that then interacts with the community and has this bi-directional relationship, because the community insights are helping inform a program and their community partnerships, and then we are working together with them. So that's the information and the knowledge is flowing both ways in that sense. We are also learning from the community as well as, so it's really a community engaged and community-based work, and it's not necessarily research. Really is focused on that implementation, and research is part of it, but really the idea is to serve our communities with evidence-based programs that address local needs. Next slide, please. So exactly this. How do we decide what programs to implement? We have two main mandates, I guess. One is any program that we implement has to be evidence-based, has to come from a place of robust research, or at least, the idea that it's evidence-based, solid information that we are providing to our community members and our program participants. I say community members because in our part of cooperative extension, which is family, community, health related, we focus a lot. Our primary audience is the community member. Extension also does work in agriculture and youth development. I didn't address that, but those their program participants might be different kind of stakeholder, like a dairy farmer, or a school, or a youth program. So just when I say community members, I'm really talking about our programs specific to the work that we're going to be discussing today. The other important thing is that the program, in addition to being evidence-based, it should address a critical issue or need, a critical local issue or need. So it's not just, oh, I want to do this program, let's do it. The idea is, does the county want it? Does that community need it? Is this their priority? And that's also how we decide what we are implementing. And of course, do we have the funds to do this? The funding, can we financially afford to offer this? But that's the ultimate trifecta that we would need, would be, can we do this? Is the program addressing a critical need? And is it evidence-based? So today we'll be talking about our diabetes efforts. Next slide, please. And this is a very brief overview because everybody here knows these numbers. These are the numbers that were updated just a couple months ago, of 115 million Americans estimated to be living with prediabetes, and an estimated 40 million living with diabetes, most unaware of either their prediabetes or diabetes diagnosis, especially the prediabetes. And that we know that there's a lot that we can do that is in the scope of our extension professionals that would address lifestyle changes and reduce the risk of diabetes or of complications from diabetes, and hopefully address that prevalence and the burden of diabetes. Next slide, please. So today we're covering 4 programs that are offered in extension at the moment. And I really want to emphasize, this is not an exclusive list. There are comprehensive lists. There are many other programs in extension. We would be here for a long time if we were to cover all the programs in extension that are addressing diabetes. So we just have these 4, and what is some similarities and differences among them. So the diabetes prevention program is a program that was developed outside of extension by the CDC initiative, and we're adopting it. And the other 3 were developed within extension through the extension researchers. And a couple of them, as you will see, are offered across multiple states. And then one is just starting and hopes to expand across state lines, because we do partner in that way. And that's really what I hope also comes across today. So the next slide, please. The first program that we'll be talking about is the diabetes prevention program. And I will pass it on to my colleague, Allison Berg from the University of Georgia, who will take it from here.
Thank you so much, Vanessa. I hope everybody can hear me okay. My name is Allie Berg. I am an extension specialist and professor at the University of Georgia in the Department of Nutritional Sciences. And so I have the opportunity today to share with you about the National Diabetes Prevention Program. So I know this is a very learned audience, and so we'd like to start out with just a quick poll question about how familiar you are with the National Diabetes Prevention Program. Please answer this poll question, because based on how you answer, I may spare you some time and skip through a few slides. Most people have heard of the DPP at this point, and I would imagine that this group is one that knows a lot about it. So we'll give it just a second, and then Sarah, if you can go ahead and maybe share those results. All right, so many of you are familiar to extremely familiar with the program. And so I will go through the background on the program, but I might gloss over a few things that certainly we can share some resources to get you more familiar. So next slide, please. So as Dr. De Silva mentioned previously, lifestyle change works for preventing type 2 diabetes. Many of you are probably familiar with the original landmark randomized control trial of the diabetes prevention program, in which they tested lifestyle change against metformin and a placebo. And what they found out is that lifestyle change is extremely effective. So individuals who lost 5 to 7% of their body weight decreased their risk for developing type 2 diabetes by about 58%. And among those who were 60 and over, they actually decreased their risk by 71%. So extremely effective for decreasing the risk for type 2 diabetes. And those effects were sustained over time. So there were a number of follow-up studies that were completed and showed that those who participate in the lifestyle change program maintained that reduced risk over time. So 34% lower rate of type 2 diabetes at 10 years and 27% at 15 years. And there's been a lot of work to really look at the return on investment of this particular program. There's a variety of estimates, but they estimate that it's a return of about 42% of return on investment, which is really great for a preventative program. And some of the most recent data actually estimates that just enrolling in the program and going through a session or two can save a participant up to $2,300 per year. So even just putting people on that track for prevention seems to be positive. Next slide, please. So over the years, as they've moved from the randomized control trial and these follow-up studies, the CDC really took on the DPP as part of a larger effort to really increase awareness of type 2 diabetes and prediabetes and get this intervention out to communities. There's been a lot of implementation science and translational science conducted around the CDC program. And now what we have is a standardized program that can be delivered across clinical and community settings across the nation. So there's, as it stands currently, a CDC-approved curriculum. You have a trained lifestyle coach. So there's training offered by specific entities across the nation, and you get trained to deliver the program in the way it's intended, not only on the content, but also on the facilitation techniques. Because this program is really about group support, and the coach is really more of a facilitator than a teacher. You do a lot to engage the participants and get them talking to one another to discuss how they deal with day-to-day challenges of making healthy choices. And so we say we rely on the wisdom of the group. CDC helps ensure that programs are delivered with high quality. So they maintain a system of recognition that helps to recognize those programs that meet certain standards and can really demonstrate positive impact. And so as Extension, many of us have been working together to get more organizations on board to deliver the DPP. Next slide, please. So the curriculum itself, the overall goal for the participant is similar to what it was in that original trial. The goal is for people to lose about 5 to 7% of their starting weight, which is a modest amount, and get at least 150 minutes of physical activity per week. The content of the curriculum is really accessible. You know, it focuses on healthy eating, physical activity, and behavior change and stress management. And the structure is a bit unique in that it goes for the entire year, since evidence shows that it really takes that year to make a lasting behavior change. You go for about once every week for about the first 4 months, and then down to every other week, and then to once a month for the remainder of the year. And there are about 26 modules. So really, I noticed earlier folks said that CHWs and the health department and others in their community offer diabetes support. And so really this curriculum is designed so that anyone can really get trained on it and deliver it and achieve those results. But we do think that Extension is particularly poised to deliver it and to deliver it well and in a sustainable manner. Next slide, please. So currently the curriculum can be delivered in person, in a distance format, so using Teams or Zoom or any of those virtual engagement methods. And there are even asynchronous versions where folks log on, sort of get the content, and then interact with a coach either via email or discussion groups or things like that. Most of our organizations are delivering in that in-person and distance formats, but there are a few that are taking on this asynchronous mode. Next slide, please. So as I mentioned, I am currently serving as chair of the National Diabetes Prevention Program Cooperative Extension Working Group. I don't think I mentioned that, but what I did mention is that we are really interested in expanding the national DPP through extension. As Dr. De Silva mentioned, we want to have programs that are evidence-based and also meet local needs. And the DPP is tried and true. It is one of our best evidence-based programs out there. And we know that extension is really great at delivering health promotion programming. And this one really meets the needs of so many of those individuals living with prediabetes or at high risk for type 2 diabetes. So we have this working group. The QR code goes to our website. But we are really looking to bring on more states delivering this program through extension and then supporting each other in being able to deliver that program. So looking at different implementation models, different ways for sustainability and structure. So we have about 25 states. We also have Guam included, and there's probably people delivering the DPP through extension in these other states that are not highlighted, but may not be yet a part of our group. Next slide, please. So one of the things we're trying to do is demonstrate how extension does a really good job of delivering the DPP. And so a few years ago, about 12 of those states got together to seek an aggregated report from CDC about our extension-specific data. And so what you can see here is a comparison of those states to what was the best available data at that time, the Eli 2017 paper. I know there's new data, but it's actually quite similar still. But you can see here that the DPP goal for weight loss is about 5%, and our cooperative extension states and organizations were averaging about 5.9% compared to the national average of 4.2%. Similarly, our physical activity rates are higher than the national average of 152 minutes, where we're at about 207 minutes per week. Next slide. And so in addition to our physical activity and weight, which are those two, primary outcomes or participant goals, we also do a really good job of retaining our participants. And we think that that's one of the real strengths of extension in delivering the DPP. You can see here some comparison of our Georgia data to the national average, showing that we are far exceeding the median number of weeks and the overall retention rates in the DPP compared to national averages. And we really believe that that has a lot to do with that local connection that we have. A lot of our educators already know these folks living in their community, so they have those existing relationships, and they're really good at maintaining those relationships, finding additional wraparound services for participants, and really just ensuring that they feel supported and want to stay in the programs. And so we really feel like that's a really big piece of gold within the extension system and really all of these programs and not just DPP. Next slide, please. So our strengths also reside in who we reach. Vanessa shared that lovely county map, and we are able to, really reach out into communities and include all of those priority populations. Some of our states use different models for implementation, including some paraprofessionals from other programs, so they can reach specific racial and ethnic groups or low-income populations. As I noted, our outcomes, weight, physical activity, and retention exceed those national averages. Next slide, please. But like any organization, we have challenges and opportunities. We are heavily reliant on grant funding. As Vanessa mentioned, we are nonprofits, we're universities, and so we're usually trying to offer these programs for free or at very low cost. And so most of us, including myself, use our own research appointments and outreach appointments to get grant and contract funding to support our work. Some extension organizations don't love that the program is high touch, low reach. So a lot of people over a long period, or few people over a long period of time. But we feel like the benefits really outweigh the costs, and that extension is recognized for our health expertise and impact. So people see extension as a trusted partner for healthcare. We are exploring that third-party reimbursement through Medicare and private insurance. We have a few states who are able to bill, but we run up against some university restrictions at many of our states for being able to do so. I think we probably all could use additional connections from the medical system for referrals, and I know one of my colleagues are going to talk about how they do that in the other programs. And there's a lot of opportunities for research and implementation science. We've done several studies here in the state of Georgia, and I know my other colleagues on the call have done so as well. And we believe that a huge piece of this program for us is retention in the DPP is retention and extension. It helps lead to other programs. And like I said, we offer wraparound services, but also other like financial health programs, behavioral health programs. And so we really feel like we are a resource that I think it was said earlier is untapped or undertapped for all of these services in addition to diabetes. So I hope that gave you a little perspective on the DPP and extension's delivery of the DPP. And I'm going to turn it over to my colleagues, Dan and Lisa, to talk about dining with diabetes.
Thanks, Dr. Berg. I'm Lisa Graves, Interim Health and Human Sciences Program Leader and Assistant Director for Purdue Extension. My colleague Dan Remley, Associate Professor and Field Specialist with Ohio State University Extension, and I serve on the leadership team for the National Extension Dining with Diabetes Working Group. So before we share a little bit more about this program, I think we have a poll question to see how familiar you are with this program. So we'll give you just a second to answer that question. All right, hopefully everyone's had a second to respond to that question. Shall we see the results? Okay, all right, about half of you have never heard of it. 13% a little familiar, 7% familiar, and then we have a few of you on the call that are either very familiar or extremely familiar. So in looking at some of the participants, I know we've got some individuals in the audience who actually deliver the Dining with Diabetes program. So we have quite the spectrum here. Just a little bit about the history of Dining with Diabetes. It was originally developed by West Virginia Extension Service over 2 decades ago. And with the success of this program, many states adapted the curriculum for use in their own state. So in 2013, the National Extension Dining with Diabetes Working Group was formed to provide leadership and coordination for unified delivery and evaluation of dining with diabetes across the National Cooperative Extension Service. Next slide. So Dining with Diabetes is an evidence-based curriculum that provides a practical approach to managing or preventing type 2 diabetes. And the target audience for this program includes individuals who are either at risk for type 2 diabetes, individuals who have prediabetes or type 2 diabetes, and their caregivers. The curriculum content is based on the American Diabetes Association Standards of Care and incorporates the ADCES-7 self-care behaviors. On the screen there, you can see the 5 program goals for Dining with Diabetes. The program content emphasizes the relationship of nutrition and physical activity in diabetes management, and it equips participants with self-management skills, including goal-setting activities that allows participants to practice these skills and gain confidence in using them. One of the favorite features of this program is that there is a food demonstration component where participants are able to observe how to apply the knowledge that they've learned related to food preparation as a part of those food demonstrations. And of course, if you have food demonstrations, you also have to encourage some tasting of those recipes as well. This program also tends to act as a support network too. So for many, it gives them the opportunity to talk with others who are facing a similar journey with diabetes. Next slide. The Dining with Diabetes program consists of 4 weekly sessions that are taught by either an extension educator or agent, depending on the state that you're in. We have different terminology for our professional staff. Many states also co-teach the program with a community health partner. And that community health partner can be incredibly helpful in answering questions that are specific to an individual's particular health situation. So the health partner could be a registered dietitian or a certified diabetes educator, for example. A reunion session is held approximately 3 to 6 months after the final weekly session, and the topic for that reunion session is really determined by the participants. It can be tailored as such. So it might be something where if the program's offered closer to the end of the year, there might be a holiday cooking session. It could also be a topic on cooking with herbs where we involve our agriculture and natural resource extension educators. It may also involve inviting a guest speaker from the local community, such as a pharmacist, to talk about the importance of immunization. So a lot of opportunities with that reunion session. So each weekly session consists of a presentation as well as the food demonstration, and the program can be taught virtually or in person. Next slide. The program participant registration cost varies by state, and this kind of depends on several different variables. Number one, depending on the recipes that are utilized within the program, there are obviously food and supply costs. So that's one of the factors. We also provide our participants with a packet of materials or a binder of materials that they can then utilize within their own homes as they review the material and apply that to their situations. We also might include an honorarium for some of our clinical partners. So the cost kind of varies depending on the state and what components they include with the program. Many, like the DPP, many of the states are actively seeking out grants to support this work to help defray the cost for our participants. So next, I'll turn it over to Dan to discuss the evaluation.
Thanks, Lisa. I lead the evaluation committee for our national group. And just a little bit about our evaluation. We have surveys that we administer pre, post, so before the 4 lessons, after the 4 lessons, and then 3 to 6 months, which usually occurs around the time of the reunions. And we use Qualtrics to collect our data. And so we do offer this program virtually in certain counties and communities. And so, participants are able to take an online survey. And in many cases, in the more traditional in-person classes, we have paper and pencil, which the educators collect, and they'll enter that data into our Qualtrics. And so we do have like state, county, and national reports. And if you go to the next slide, please. So our states will get their state level reports, in some cases county level reports, and the counties can compare like their numbers to their data to the state and the national, so they can compare like their knowledge and behavior changes to those benchmarks. And so we do have a compendium of literature, of peer-reviewed research articles that support the evidence for this program. I'd be happy to send that out. But these are some of our 2025 national outcomes, and we only have 6 states that participate and about 658 participants, and we're hoping to grow that number. But as you can see, we have pretty good results when we measure different behavior changes from before to after the program. So within that 4-week time period, 5 out of 10 are improving the number of days that they report physical activity for 30 minutes or more. 5 out of 10 are eating, the recommendation for vegetables. 5 out of 10 are reading food labels more often. And then 6 out of 10 are using the plate method to guide their meals more often. So we're seeing really nice behavior changes. And I will say, too, that these behaviors are sustained at the 3 to 6 months. We also measure knowledge. And so we ask people questions about nutrition, physical activity recommendations, diabetes complications, diagnostic tests. And we do see pretty good results from before and after. And then we see that knowledge gain sustained as well. We do measure hemoglobin A1C pre and then at the 3 to 6 months follow-up. Now, this is self-report. We don't actually measure we do not do the blood draws, but we do see in terms of the self-report, we are seeing about half of our participants self-report some sort of decrease in their hemoglobin A1C. Next slide, please. In addition to the sort of those quantitative questions, we have an open-ended question. We just ask people, what did they learn from participating in Dining with Diabetes? And so these are some of the themes we see from that open-ended question. So people are having a better understanding of nutrition concepts and label rating. They understand portions better. They understand the kind of the plate method strategies. And a lot of them at the follow-up are also saying that they've made a lot of behavior changes in terms of the number of days they participate in physical activity, strength training, those types of things. And some will report their decreases and their and their improvements in their hemoglobin A1C. A lot of people love the recipes, and they talk quite a bit about how they learned how much they love these recipes and how they've learned to make healthy substitutions in their recipes. And then finally, just understanding diabetes and complications and diagnostic tests and those types of things. And so a lot of our people that come to our classes are newly diagnosed, and they're kind of like deer caught in headlights. And so we're able to help them become more self-confident in understanding the diabetes and also taking charge of their management. Next slide. So just some of our benefits and challenges. Our program is pretty easy to follow. It's very didactic. We have 4 PowerPoints, and as Lisa said, the reunion is a lot of flexibility there in terms of who you invite. You might invite a pharmacist. And we have the teaching materials are provided by our national group. We have recipes, and the taste testing is very, very popular as well. It's a pretty short series, so it's only 4 weeks, and we have that reunion. And we do recommend that our extension educators find a clinical partner to work with. And so that's important too, especially if they don't have that training in nutrition or aren't registered dietitians. So that, especially if they get those questions about medications, the clinical partner can take those and easily address those questions. The food preparation and planning can be somewhat time consuming. And then, as I mentioned earlier, we don't collect that metabolic data. We do the self-reporting for the hemoglobin A1C. Next slide. And Lisa talked a little bit about our history, and we've been around since 2012. We do have our committee functions to coordinate Dining with Diabetes and the evaluation. And so we have sort of subcommittees that work on the curriculum. We have an evaluation committee, and then we have a professional development committee that trains new counties and states that are interested in teaching it. And we also have a committee that works on trying to reach out to some of those non-traditional audiences. And so we have a lot of our materials in Spanish as well. And so I think that's my last slide. And I think that Kathy is next.
Thank you, Dan. This is good. Sorry. I'm sorry, I thought I interrupted someone. This is good trajectory because we're an offshoot from Dining with Diabetes. So, but first, I'm supposed to ask the question, which I expect no one really knows, about balance living with diabetes. It'll be interesting to see if people have heard of it or not, because it's a Virginia-specific program so far. I do know we have one Virginia person on who's actually taught it. See what we got. Yeah, we got one extremely familiar. That must be Claire Lillard, who's from Virginia Cooperative Extension. And another person said that's good. But most of you, as I expected, haven't heard of balance living with diabetes. But I'll tell you about it and where it came from. We can go to the next slide. Next slide, please. Thank you. So I will say that Balance Living with Diabetes, you'll see on the next slide, we adapted it from Dining with Diabetes a long time ago, back in 2010, because of an NIH research study that we were doing, but it remains very much true to the original intent. It's community-based. We offer it in community settings, not typically in clinical settings, and we focus on nutrition and physical activity, and we do want our participants to communicate with their healthcare provider if they have one. Like Dining with Diabetes, it's guided by social cognitive theory, and that's really something that we've kept really at the center as we've done a lot of iterations, and we focus on self-efficacy for these behaviors, self-regulation, outcome expectations, and social support. And the way we do those things primarily are these three that you see here. A lot of individual goal setting and tracking. You'll hear a little bit about that in the next slide. We use the plate method like Dining with Diabetes. We want something that is fairly simple that people can follow and not have to do a lot of calculations, that sort of thing, because it is for people who don't typically go for clinical education in a clinical setting. And something that we've added most recently is the exercises during the class sessions. But I'll talk more about that on the next slide. Okay, so here's the evolution. In Virginia, we did have Dining with Diabetes in the early days from 2006 to 2010. And then as we were looking for, I became involved at that point, and we were looking for additional funds to do more of this. And I realized what an amazing outcome we were seeing with A1C. And so we wrote a grant proposal to NIH, and we were funded the second time around. And during that project, which was community-based participatory research, is when the evolution started happening. Wasn't really by design, but as we were working with our participants and our church congregations, it was in partnership with Black churches in Virginia, it just evolved. And you can see that the name evolved to Balance Living with Diabetes, the logo, the focus on food and fitness. They really were focused on the fitness part of it too. And so that's when the big evolution happened. And then we got subsequent funding for rural delivery from USDA, and most recently completed a project funded by CDC to evaluate their New Beginnings support program, social support program. And so you can see along the bottom there, the program name, like I mentioned, that was nominated by the advisory board for our NIH project. And I will say I didn't even like it in the beginning. I love it now, but it was just like, that's what they came up with. That's what we're doing. And the logo reflects the different parts of diabetes self-management. And then the iterations that we've done since then have been based on focus group discussions with participants, especially with the NIH project, where they told us things like, well, I'm not doing any more physical activity. We don't talk about it very much. They tell us about it. We don't do it. So then we knew that we needed to include more exercise during class, which we're afraid to do because they're at risk for heart disease. Self-efficacy, they said I kept track of everything and people didn't even look at it. I kind of stopped after that. So you can see on the right side of the slide, what we've done through the years is to increase the number of sessions from the original 4 to 6, because we didn't want to take any content out, but we needed more time for the participants to interact with the extension agent about what they were doing and their goal setting and their tracking, and also time for them to practice exercises. So we had a Master of Public Health student who happened to be a certified trainer who put in the exercises at a very moderate level, and you'll see some pictures of that. So that was the evolution over the years from Dining with Diabetes to Balance Living with Diabetes. They're both very similar in delivery and content. Ready for the next slide. So our priority population, as is for a lot of our programs in diabetes, is people with type 2 diabetes. We have people who come who have prediabetes. We don't require it, but our priority population is people who are living with type 2 diabetes. Sometimes they don't know it till they get there, and especially those who are having trouble controlling their diabetes. And especially those ones with number 3 there who have not even had diabetes education. They're either they don't have access to it, or they're not comfortable going to a clinical setting. Those types of people who are living with diabetes, who are way more comfortable because they know our extension agents and they are happy to come to a church or to the YMCA. We've had firehouses, different places where we hold the program. Next slide, please. And so the general structure is very similar to the other programs that you're hearing about. We have weekly classes. They're about 2 hours, sometimes an hour and a half. And what we have in that, you'll see later. So it's weekly for 6 weeks. Started out 4 and now it's 6. And then we have that reunion class, like a lot of ours do, about 2 months after the last class. And the main reason for that is to allow time for the A1C to change as much as it's going to after our participants have made those behavior changes. The assessments that we do at the first class for baseline, we do measure A1C. We do the finger stick with A1C now, and we actually do 2 of those for each person just to be sure we're giving them good information. And we measure their weight, not their height anymore. We used to, but we just do the weight now. And then we have, like Dan mentioned, questionnaires that we administer that measure diabetes self-management behaviors. And we measure self-efficacy, social support, and self-regulation because of the social cognitive theory underpinning of it. And we do encourage people to bring their family members or their significant others who help them with their diabetes self-management so they can learn it. And those are real pictures from our program that you see on the slide. Okay, next slide. Okay, and so the structure that we have, and you can see these are pictures from actual classes in the past year, is that we have an extension agent who coordinates and leads most of the classes, but the first 2 classes, we do contract with local CDCES, RDs, nurses who are trained in diabetes so that they can talk about the clinical part of diabetes, what it is, what insulin is, answer basic questions from the participants. And then the extension agent does the bulk of the instruction other than that, practicing with the plate method, reading labels, recipe alterations, things like that. They introduce the exercises and the participants, as you can see in the lower slide, they do exercises and they do stretch band type things in class, very low level. And we do the physical activity readiness questionnaire for those who are thinking about that. So the participants know if they're safe to do these exercises and to check with their healthcare provider if they have a high score on the physical activity readiness questionnaire. Lots of practice, lots of personal goal setting, sharing with each other. We really have people encouraged to share with each other what they've been doing since the last class period. And we have little logos on the slides for the instructor that we call the praise logo. That's back from our church origin. That if it's a slide where you're supposed to be encouraging participation, that gives the instructor remembering to encourage and praise the participation. Okay, next slide. Thank you. And so these are some outcomes just from the last year. We had a lot of participants because we had the CDC study that we were conducting. You can see the mean A1C separated out for those who started with over 7, which is the target for glucose control, came down. We haven't done statistical analysis yet because we're still collecting data, but it came down so much from 8.5 to 7.8 as a mean. And we did have increase in participants who did some of the other target behaviors. I was looking at fruits and vegetables and then whole grains, which is not on this slide. I noticed with our slide, our number 3, we need to change how we can talk about the change in exercise because you can't really go 0.4 days. It's kind of like having 2.5 kids for the mean for the US, but activity did increase both strength and cardiovascular. Physical activity did increase for the participants who were in the program. Okay, next slide. Right, as far as our benefits, challenges, and opportunities, very similar across all of our programs. The benefits are that we do have a great set of tools for our participants, and we have a lot of interaction with the participants, with each other, with the person who's teaching, the person who's doing the food demonstration, which I didn't mention, but we have food tasting, food demonstration as well. And people walk in and they'll say, "What are we having today?" And they can smell it being cooked while they're in the class. We do have master food volunteers who help with our food demonstrations, which gives the extension agent the ability to focus more on the delivery, the program delivery. Not all of them have the master food volunteers, so that's a challenge sometimes. A1C testing, real-time feedback on A1C, and a lot of people are surprised and they celebrate at the end when it goes down. And we use, as I mentioned, the A1C Now kit, and we are CLIA certified. We have a CLIA waiver so we can give the feedback to the participants. We learned that from our health department that we have to have the CLIA waiver in order to actually give the results back. And we check off whether it's in range or not, depending on their diabetes status. The challenges that we have, similar to what Ali mentioned, we have not all of our family consumer science agents are able to conduct it because of the heavy lift and because it's not the big numbers. And so we're working also to help them see the benefit and the big impact that we're having with those participants for those 6 sessions. But it's a lot to give up time to do this program versus the bigger reach, like cooking for 500 and things like that. And our recruitment and retention has been a lot harder since COVID. I think all of us are probably seeing that. It's harder to get people to come out, but the retention is really good once they're in the program. So that's a big challenge that we have. Opportunities with these outcomes that we're showing, as you could see, we've had really good funding success. And I think the more we collect the data, work together across states to really show the benefit of what extension can offer and the high impact for the participants in our program, really think that that's where we're going next with our diabetes program across the United States. And I will pass it off to my colleague Windsor from Clemson.
Greetings. Thank you so much, Catherine. I'm Windsor Sherrill from Clemson University, and I'm delighted to represent my partners at Clemson and UGA to talk to you about the Health Extension for Diabetes program. Same theme as others, all about how the Extension Network is uniquely well suited to deliver these diabetes support programs because of the trust, the community connection, the familiarity with community, saying things and having better retention and better outcomes, really facilitated by our extension facilitators, our extension agents. Next slide, please. Oh, first of all, I'll be delighted if any of you are familiar with Health Extension for Diabetes. Have you heard of the program before? We might have a few people on the line who are partnering with us. We have some states, Tennessee, Georgia, Alabama, North Carolina, who are partnering, but I'm curious if others have heard of the program. So when we get the poll results, we'll put those up. But Health Extension for Diabetes is a copyrighted program from Clemson University and licensable from Clemson University. We have some folks who are familiar. Glad to see that. And so I hope after today, you'll be even more familiar. So we started the program in 2017 in partnership with a large healthcare system in South Carolina, focusing in one particular county, and we have since expanded to 41 of the 46 counties in South Carolina. Next slide, please. The Health Extension for Diabetes program is delivered in collaboration with CDCES clinicians and DSMES programs. As you all know, if others have mentioned the importance of a clinical connection, and we recognize that clinical connection both for referral to the program from clinicians as well as specific support during the program is so helpful to have that clinician partnership because, as we know, our health extension agents are not licensed clinicians, but they have this unique ability to be very incredible health navigators and health educators. We received a significant boost to our program when the ADA recognized Health Extension for Diabetes as a practice-tested diabetes self-management support program. Again, we follow ADA standards. Each year, the program curriculum is reviewed very carefully vis-a-vis ADA standards, and it's updated annually. Next slide, please. So how does the program work? Health Extension for Diabetes is a bit of a parallel to the DPP program. DPP is for people who are at risk for diabetes. HED is for individuals who are living with diabetes. So anyone with an elevated A1C, with a diagnosis of diabetes, it is not for people under 18, and it's not for people who are pregnant or have advanced kidney failure. The program is 4 months long, 8 bi-weekly sessions, again, structured around ADCES standards. And the bi-weekly curriculum is very structured. And then interspersed after the curriculum of the 8 biweekly sessions is individualized follow-up. Also, significant resource navigation. As you all know, as we've said, each extension agent knows their community. They know the resources in their community, such as food banks, physical activity support programs, other initiatives that individuals can access within their communities. They do a lot of navigation, not just for individuals through the program, but also referring individuals outside for other support. The program is offered in person at community sites or online. We also offer it in English and in Spanish. That CDCES clinical partnership is critical in the 4th session of the program, which is about medication and monitoring. That session is given by a clinician partner. We also have something called Ask It Basket questions. We don't want our extension agents to feel like they're having to answer out of scope practice questions, and those Ask It Basket questions go to the clinical partners for answers and follow-up. A license is individuals and institutions can become licensed to provide the HED program through Clemson. Next slide, please. We were super pleased to receive CDC 2320 Part B funding to take the program to 4 neighboring states through the land-grant universities, UGA, University of Tennessee, North Carolina State, and Auburn University, and the Alabama Cooperative Extension System. So again, we've reached 41 of 46 counties in South Carolina, and now we're working with these states through a 2320 CDC funding to expand to those states. After we received the ADA designation, CDC listed the HED program in their 2320 NOFO, and that enabled us to do these partnerships. Next slide, please. We're very focused on accountability to outcomes in the Health Institute for Diabetes program, really in the buckets of diabetes-related knowledge, diabetes-related behaviors, and health outcomes. So we're very intensive and very intentional to do pre, post, and 1-year data collection in these categories of participant demographic, social determinants of health, biometric data, including weight, BMI, and A1C, nutrition, physical activity behaviors, self-efficacy, diabetes knowledge, and complications. So all of those things are assessed pre, post, and 1 year. Next slide, please. And this is just a snapshot. These are our Georgia cohorts. We've actually served over 2,200 people with the program so far. In Georgia, we've done 18 cohorts just for the first year. The cohorts that are largely often male, but we have pretty good diversity as far as racial diversity. And we are focused on reaching those older cohorts. Our average age in Georgia is 64 years old. We see improvements in diabetes self-efficacy, diabetes knowledge, that's a 10-item score, and A1C. So we've seen and we've published on the results that after HED, our participants have significantly increased their self-efficacy in managing the diabetes and their diabetes knowledge, and also their diabetes-related nutrition and physical activity behaviors. So very pleased about those results. Next slide, please. So you've had some, just like all of these programs, great opportunities and also challenges, of course. Our collective impact is particularly getting to expand the program to neighboring states, and I'm partnering with states and thinking about how it's very different, and every land-grant system is different and how they have different challenges. That's giving us an opportunity to really do some strong implementation research to collaborate across our land-grant universities. We've also had a chance to do several new grant proposals with this initiative. Once we received the initial funding to do the very first county in South Carolina, we expanded beyond with state funding. We had a health system provide us funding. We received funding from the American Diabetes Association to look at electronic health record tools to facilitate referral. And as I mentioned, we've also had CDC 2320 funding and CDC Community Connections funding to support. But just like others have said, we've been very, very grant focused, and we really hope at some point to have third-party payment funding for this sort of program. So can provide lots more information. We want to have some time for discussion for this group. So I'm going to turn it back over to Lisa. I'm delighted to tell you guys about Health Extension for Diabetes, and would love to tell you more about it in the future.
Thanks. So now that you've heard more about these 4 diabetes education programs offered by Cooperative Extension, this quick reference chart outlines the similarities and differences between each of the programs discussed today. So the number of educational sessions and the overall duration varies by program, ranging from 4 weekly sessions up to a full year. All programs are available in person, and several have options for online, virtual, or asynchronous viewing. The evaluation components range from participants completing surveys to an intensive evaluation. And then the majority of the programs are currently available in Spanish. The Dining with Diabetes curriculum underwent a curriculum revision recently, and so we hope to have a culturally relevant curriculum soon. Next slide. The licensing and training costs vary by program, and each of the programs also have some unique features, such as access to CDC participant support tools, cultural recipes, integration of vaccine education, or specific partnership requirements. Before the end of the presentation today, there's going to be a slide with contact information for each program. So we encourage you to reach out to the program contacts with any questions that you might have. With that, I'm going to turn it back to Dr. De Silva to lead us in some discussion.
Thank you so much. Thanks for everybody. I know towards the end, there's so much to cover. So I appreciate everybody for sharing about your programs, and I wanted to see if anybody had any questions. Let me check. Please type in the Q&A if you had any questions. There's been a couple. Dan, thanks for already answering that, but I wanted to give anybody the opportunity to ask if you had any questions. Question I had for the panelists, we talked about your programs and a lot of the challenges and needs for collaboration and all that. So I was wondering, from your perspective, what is a good way to ensure that any collaborations between extension and non-extension researchers, whether within your university or from a different university, provide value to all the parties involved, including the communities that we are serving? Anybody want to go first?
I would love to take a stab at that because I'm actually not extension faculty. I am public health sciences faculty, and we're really proud of the fact that we actually partnered across a public health sciences unit, and our faculty do a lot of the evaluation and research with our extension partners deliver the program. So we think it's just a perfect marriage. But we had to get used to each other. We're in different colleges. And so many of you all will deal with that same opportunity/challenge, but I think you really can dig down and get a lot of expertise and methodology across your universities by partnering beyond with other departments. So if you have a public health department or a medical school at your university, please consider it. We've really had a great time with it at Clemson.
There's some questions about recruitment. Does anybody else want to chime in about the partnerships from a perspective of an extension faculty to just balance out Windsor's perspective? Ali or one of the others?
I'll chime in real quick. It's really been an opportunity for extension, our agents, to need to reach out to healthcare partners, which is not something that we've done that much before. So it's really helped them establish more relationships in that realm. They had relationships with food banks and with other ones of our partners and YMCAs and all of that, but to need to find an RD, CD, CES to help us with that has then led to more awareness of the healthcare partners, about referring them to our program. So that has worked really nicely.
Vanessa, I was just going to add that, you know, when you work with extension, I think a lot of times we're approached as to help with recruitment for studies, and we absolutely can do that. But it is also really important to consider what is maybe the researcher or the group's teams give back to extension. Because there's a lot that we can provide and do for communities, but we really want to be your true partner, your, you know, real partner in these efforts. And so how you can think about how you can give back through your own expertise or resources. If you're early enough in planning for grants and projects, you know, having time or effort on that grant if possible, or materials or travel, those things are great. And in many of our states, our extension county-based faculty are also faculty of the university with their own like scholarly and promotion requirements. So really just trying to get to know who your extension partner is and maybe what their needs are so that you can have a mutually beneficial relationship.
And your comment about recruitment ties really well with the question here, which was, can we talk about recruitment methods? People are always curious about our numbers and the amazing, you know, because we have an amazing number of people that we are able to engage with over a year. So does anybody want to talk about recruitment methods? Again, knowing that it will look different in every state and every county community, but
I can start. I will say that I cannot underemphasize the importance of community partners. And so working within communities to identify those groups that have access to audience that could benefit from these programs has probably been the number one way that we've been able to ensure that we have audience participation in these programs. So whether that's a community-based organization or, again, a healthcare partner or local health department, those community partnerships have really been integral to ensuring that we've got audiences willing to participate in our programs.
there's a lot of questions, so I'll keep going through and try and make sure I get them in the chat and in the other chat. There was about recruitment. I think there was a question about retention. Let me find that here. What strategies have you found to be most effective for sustaining engagement and retention in community-based diabetes programs, particularly in historically underserved communities? What qualities do cooperative extension programs look for in community-based implementation partners when developing new wellness initiatives or pilots?
I'll just add one thing. We've had great success. Some of our program facilitators are new graduates from nutrition and public health sciences, and they have just amazing energy. It takes a lot of energy and just loving on people in communities to get them to feel like, I want to stay in this program. So just the person-centeredness, I think makes a big difference. And I think we look for that in our agents and our program facilitators. And sometimes particularly somebody who just has a lot of passion around this makes a big difference. That's kind of a unspecific characteristic, but it works when we see it in practice.
I would add to that, Windsor, that like, you know, most people who get into extension do so because they are very people oriented. And so they kind of naturally will reach out to folks in between sessions, right? And look to maintain that contact. And one of the beauties of extension is that we are local. And so you might see a person in the grocery store or at the gas station or something like that. So having that additional contact outside of the sessions, I think, is a huge piece of why we have the retention we do. And then also just the natural inclination of our agents to be that people person, to love on people, like Windsor said, I think is a huge piece to why we were able to retain. And lastly, from like a sustainability perspective, you know, it's our mission to deliver educational programs. And so while others might take on some of these programs as in addition to other parts of their job, like I know we've seen that here in the state of Georgia with public health, is that sometimes there's not enough room in the day. And that can be the case with our agents, but also they have a mission to provide these educational programs. And so it fits within their job, which I think helps us for long-term sustainability.
Thank you. There was a question from Nadia about How has Extension been involved in cultural adaptations of the programs for the communities, adaptations for diverse racial, ethnic communities, and limited English proficient populations? And that will be tied with another question about the What Can I Eat program that is a diabetes nutrition education program from the ADA partnered with IHS, which is a culturally adapted program targeting really tribal adults, or again, which is very heterogeneous, but to the best of their ability. So that was an example. That adaptation did not happen through Extension for What Can I Eat. We have adapted things through Extension. So the question is, what has that looked like with your work in Extension?
I would like to tie the research side of the house and students with this question, because in our evolution of Dining with Diabetes to BLD, we were working with Black churches, and I had students who helped with the whole adaptation of recipes, but our advisory board picked recipes that they thought resonate. Then we worked with churches. They signed up to cook the recipes and had a little taste testing, and that's how we picked the recipes. Students were involved in that. But the Spanish version I really wanted to highlight was a PhD student from El Salvador, who really wanted to work with Catholic churches and translated. She didn't say interpret, she translated it into Spanish for the people she was working with, churches. So those are two examples.
Dining with Diabetes, don't sell yourself short. I know you guys have a recipe book, and you have recipes that were adapted for Native communities, tribal communities, and also Mexican American and Latino. So do you want to speak a little to that? So recipes as a form of education, right? And that adaptation there. Lisa or Dan?
I didn't know who was going to come off of mute first. Dan, go ahead.
No, I think I was going to let you. I know you've been giving a lot of leadership to the Spanish-speaking versions of our.
Yeah, so we have some culturally relevant recipes for Native Americans, and I think University or Arizona helped us with that. And so I think one of the great things about collaborating with other states across the country with Cooperative Extension is being able to tap into partners that, can work on some of that recipe, informing some of those recipes. So, I mean, in Indiana, we don't necessarily have quite the population that some of the other states have in the Native Americans, but it's been wonderful to be able to utilize those recipes with our participants. And then, as I mentioned, we've made some curriculum adaptations recently for the English curriculum, and we're hoping to do that with our Spanish curriculum then, and make sure that we have the recipes that go along with those. So not just, taking an English curriculum, but really being really intentional about ensuring that the curriculum itself is culturally appropriate and relevant.
It hasn't been easy either, has it? I was just thinking back to even our title was a lot back and forth, what that actually sounds like in Spanish. And
a lot of that adaptation, I will chime in here, is happening locally on the fly with the actual educator who knows that community and knows that the settings locally, and might be talking about foods that are in season there, or exercising. Maybe they don't have a gym, but let's go take a walk at the Walmart if it's very hot outside. So there's adaptations that are happening just for the fact that the educators are in the community serving our audience. There was a question. Hi, Betsy. How is behavior change followed and measured beyond the numbers? Anybody want to address that?
well, as I said, our evaluations are self-report, and we offer them before and after, and then 3 to 6 months. And so we only know pretty much what the surveys tell us, although we always have success stories that we try to capture those anecdotal. One person comes up to our educator and says, "Hey, I've lost 10 pounds. My A1C has dropped by 2 points." And I feel like such a better person. And we try to capture, sometimes we'll ask, hey, would you be willing to testify to some of our stakeholders or something like that? So some of those testimonials are really important to our funders, but mostly it's just yeah, what we get from the evaluations in those stories.
All right, we got a couple more minutes. Let me see if I've missed any question. How can you find out if your state's cooperative extension is participating in the national DPP? The website preventdiabetes.extension.org. We try to keep that up to date. Or you can, like I asked you, what state are you in? We might just be able to tell you to the best of our knowledge. And I think Julie, hi Julie, you asked about reimbursement with Medicaid for programs other than DPP. The only reimbursement that I know of that anybody's been successful in so far has been with DPP, but again, maybe others might know of other reimbursement successes with your programs or with any extension programs.
I think Ali touched on this a little bit. Sometimes it's a bit state specific, and some of the institutional requirements or limitations too in terms of that piece of the reimbursement model. But I know Cooperative Extension as a whole is actively seeking out opportunities for this to make it easier, because that would certainly reduce some barriers in terms of not only participants being able to access the programs, but also in terms of the delivery of the program and reimbursement for time and labor and costs and things like that.
Thank you so much. I think Emma needs to hop on and close out the webinar.
I'm so sorry to interrupt this amazing discussion, but I just wanted to say thank you to everyone, all the presenters, everyone who attended today's meeting. Clearly, there's a ton of questions and interest in these programs, which we are so excited to see. So with that, in my 1 minute, I just wanted to say, here's the contact information for all of the speakers today. However, it would be really wonderful if you reach out directly to CEDER. We will then connect you to them, and then I'll talk about that in a second. And we'll also share this recording and all of the slides as well. So with that, 2 minutes. So please take 1 minute to complete our evaluation. We are very interested in hearing what you thought of today and how we can improve these events going forward. So it really shouldn't take you too long. So if you get a chance, please complete this. We'll send out the link as well. We have another learning exchange coming up in a couple of weeks on May 20th, focused specifically on sustainability. I saw a lot of questions around sustainability, and I know this is of interest to both researchers and community groups. And so this webinar will be led by Dr. Rachel Shelton and Dr. Joshua Joseph from Columbia and Ohio State, and talking a lot about the research behind sustainability. And we will have a follow-up event in the fall from a community partners that are part of CEDER on this as well. And then, as I said before, all of these amazing speakers are part of our network, and we would love to connect you to them through our free consultations and studios. Again, this is an opportunity to connect with one-on-one or in a group setting and talk about the work that you're doing, your research questions, your community questions, and make sure that you have these programs in your communities and that you're partnering with these amazing people. So please reach out to us. It's very easy. You just fill out a quick form, tell us what you're interested in, who you are. We'll set up a meeting and we'll make that connection, again, all for free. So please reach out. It's so great to see so much interest in these programs. And we have, again, a ton of other experts on a lot of other topics related to type 2 diabetes as well, if that's what you need. And finally, please find us on LinkedIn, come to our other events. And we also have a quarterly newsletter. We just had one that went out and includes a lot of great information about the work that's happening in this space, different events and conferences, research articles, and examples of our services and highlights. So please connect with us that way. And I think that's it. I'll leave you there. And I will say, finally, we will be at the American Diabetes Association conference in New Orleans in June. If any of you are there, please stop by our table, come to our posters. We're also having a professional development session on community engagement. So we would love to see you if you're going to be in New Orleans. And otherwise, I'll leave it there. So check out our website. Thank you again to our amazing speakers and to Vanessa and to everyone. It was such a wonderful event and just amazing, amazing work happening across the country. Thank you. Have a great rest of the day.